Good afternoon, everyone. I'm Arun Joseph, and I am a DPhil in Clinical Neurosciences student at the University of Oxford at Jesus College. Today, I'm very grateful and delighted to welcome our speaker, Dr. Chiara Robba, who's a consultant in neuro and general intensive care at Policlinico San Martino in Genoa. She has worked for many years at Edinburgh's Hospital in Cambridge, and she also attained a PhD in neuroscience under the supervision of Professor Marek Czosnika. She's also currently the chair of the Neuro-Intensive Care section of the European Society of Intensive Care Medicine, and her research interests mainly are neuromonitoring, autoregulation, and mechanical ventilation. Her lecture today would mainly include incidence and causes of extubation failure, indications for tracheostomy, and Chiara would also help us understand more on the risks and benefits which are related to early as well as late tracheostomy in our ventilated patients with acquired brain injury. So thank you so much, Chiara, for being here, as well as accepting, first of all, amidst your busy schedule. And over to you.
Thank you very much, first of all, to you, Aaron, and to Jacqueline for inviting me and for organizing this meeting. As we were discussing before you were joining us, my talk will be something like 35-40 minutes, and then I think that the best part will be the discussion, because at the end of the story we are talking about a topic on which we don't have many evidence. And where basically the clinical reasoning and common sense in most of the cases are predominant. But I'm going to discuss with you which are the available evidence, and I will trigger you on some points for discussion from the practical to the ethical parts of this topic. I have no conflict of interest for this talk. And this is a sort of the agenda with sort of objectives that I would like us to achieve together. So we will discuss first about the extubation failure, causes, incidence, prediction of extubation failure, need for tracheostomy in brain injured patients, timing for tracheostomy, so early versus late tracheostomy in brain injured patients, and we will compare some evidence also with a general ICU population, and then a bit of discussion and some general conclusions. So, as always, brain injured patients are different from the other populations. First of all, because especially regarding the mechanical ventilator settings, in many cases, brain injured patients have been excluded from the major trials that have been performed. Just think about all the trials on the protective ventilation strategies. If you look at the exclusion criteria, there is always neurological issues and acute brain injury. Because they are different, there is a different physiology, and it is exactly the same regarding the weaning. And sometimes we are scientists and clinicians, we need to demonstrate this. And this is what these authors many years ago in 2009 have tried to do. Basically, they have tried to apply the general criteria for prediction of extubation, the criteria for the general ICU population, in a population of neurocritical care patients. Respiratory rate, minute ventilation, tidal volume, negative inspiratory force, PF ratio, etc. And if you look at the results of this study, they are quite scary, because if you see, there is not significance in terms of any of the variables that are generally considered for the general ICU population in terms of weaning parameter and prediction of extubation. Probably it's because the role of GCS seems to be quite important. This is the first thought that I had when I read that paper. And then I went into more details in the literature, and I found, in fact, which is reasonable and it's not unexpected, that there are some studies where basically the GCS, and in particular the motor tasks, have been found to be independently associated with the prediction of extubation failure. This is a big study. Well performed, and as you can see here, the best motor response and in particular the ability to respond and to obey to commands, as well as the ability to protrude the tongue at test, were independently predictor of extubation failure in a population of critically ill neurological patients. But evidence are not consistent in this. And this is something that is quite strange, and it's again a bit scary, because this is a very big, interesting, and well-performed study from a group of Victoria McCready, who is a friend from Canada, and with a group of great researchers, which was performed in 3 big hospitals in Canada. And basically what they did was to assess which are the variables that are associated with the risk of failure of extubation. And these are the age, so something on which we can't do anything about this, the presence of cough reflexes, the fluid balance. So the higher is the fluid balance, and the higher is the probability to have an extubation failure. But if we look, for example, at the GCS, in this case, there was not correlation or association between GCS and failure of extubation. All these studies that I showed you so far were quite big, but not as big as the ENIO study, which I'm sure you know have read. This study has been endorsed by the European Society of Intensive Care Medicine, and it was published this summer. It was led by the group of Rafael Cinotti and Karima Zenon, who are great experts on this topic, and they managed to include a huge number of patients. At the end, 1,500 patients were included in the study, and of this, if you see the differentiation in the group, 960, so less than 1/2 of these patients were those with extubation success. And all the others, brain-injured patients, were patients who underwent a primary tracheostomy, or who had a failure of extubation, or had failure of extubation and then went for a tracheostomy. And the first part of this study was simply very descriptive. They basically asked to the clinicians which were the reasons of extubation failure in brain-injured patients. And the main reason for extubation failure was the neurological impairment in the 74% of these patients. And basically what is quite clear from this study is that in reality, the principles of general ICU population are applied even in these patients, with the addition of a neurological assessment, but not specifically regarding the GCS, but specifically regarding the ability to cough and to maintain the patency of the airway. And in fact, airway impairment was the second risk factor reasons for extubation failure, and less, but still at 4%, the presence of a facial trauma. But the group of Cinotti tried to do something more. They went into the details of the patients who had an extubation failure. At the end of the story, in this huge study, the total extubation failure was nearly the 20%, which is huge. It's a huge number and much higher than the general ICU population. And they try to understand which are the factors that are associated with the risk of extubation failure. In terms of characteristic of the patients, they found, which is quite interesting, that there is a high risk of failed extubation according to the countries on where the patients were admitted. I have to say that Italy is one of the worst countries in terms of extubation success. And also France, maybe because there was also the majority of the patients included there. But if you see the percentage here, there is a huge variability. So this means that, which is true, we don't have general guidelines. I will show you in a second the guidelines that we have provided, but are really quite general. And probably there are not too strict and well-performed local protocols, which can be generalized across different countries. Another factor is the type of brain injury. TBI and intracranial hemorrhage in this first descriptive analysis were the type of brain injury that were much more associated with a higher risk of extubation failure. Consider that in the ENIO study, there were included TBI, intracranial hemorrhage, subarachnoidal hemorrhage, ischemic stroke, but also patients with CNS infection or patients with brain tumors. So with a very heterogeneity in terms of severity and type of brain injury. And then other factors that are associated with extubation failure in the brain injury population seems to be, again, the higher age, like the study that we've seen from the Canadian colleagues before, the presence of precomorbidities, and in particular the cardiovascular and respiratory comorbidities, lower GCS without a specific threshold, the threshold that we consider, for example, for intubation of 8 or 6, as it was in the previous study, are not actually confirmed. It really depends on the interaction between neurological status and ability to protect the airways. And then, of course, it depends also on some of the therapies that we use in these patients. What came significant in this study was, for example, the use of ICP monitoring or the application of tier 3 therapies, which is quite reasonable, because if a patient needs an ICP monitoring, probably needs also a treatment for the ICP monitoring. And so one of these treatments is for sure the sedation, and therefore this increase the risk of the increase of days of mechanical ventilation and probably the risk of complications. And it's the same, especially when you have an intractable intracranial hypertension. So when you need the tier 3 therapies. Tier 3 therapies are the therapies for intracranial pressure management, which are considered the more aggressive, and are the barbiturates, are the compressive craniectomy, and are the hypothermia. These according to the Seattle guidelines for the management of intracranial pressure. Clearly, if the patients need one of these three therapies, is a patient who has more severity and who is probably at higher risk for side effects from the tier 3 therapy itself. And then Raphael and colleagues did another step forward. They tried to build a model which could help the clinician to understand at patient's bedside which is the rate of extubation success. And basically, they found, I have to say, not a great sensitivity, but anyway, an acceptable area under the curve of 0.71 with 7 main predictors. So the presence of a TBI is a predictor of extubation success compared to the other types of pathologies. The presence of cough and gag reflex, endotracheal suctions less than 2 times an hour, GCS higher than 6, and the body temperature. As you can see, if we go back to the first slide that I showed you, when I said brain injured patients are different from general ICU patients, this is the demonstration, because these are not generally considered in the criteria of a general ICU population, and take in consideration different factors, respiratory and neurological factors, but especially the presence of cough and gag reflex swallowing. Shaurya Taran is a very good scientist and researcher. He did his PhD in Canada, and now we are collaborating a lot in several studies on mechanical ventilation in brain injured patients. And last year, he decided to perform a systematic review and meta-analysis regarding the predictors of extubation failure in acute brain injury. And as you can see, he found a huge number of studies, and he put together all the factors, all the studies which were heterogeneous in terms of outcome, so extubation failure, and he tried to put together all the data and the studies that I showed you so far. And what he found when doing the pooled analysis of this is that the higher risk factors in terms of extubation failure are the age, which is something on which we can't do anything. It's an unmodifiable factor. The duration of mechanical ventilation, it's partially modifiable from our therapy. It's something that anyway we have to keep in mind. But at the end of the story, putting together the studies, the presence of the GCS, and in particular the neurological assessment using the GCS, was not a predictor of extubation failure, whereas cough and swallows were. So this is what we have put together with the European Society of Intensive Care. Keep in mind that these are guidelines from 2020, so If you see here, there were no evidence at all, or very, very, very small. And this evidence came mainly from the smaller studies that I showed you before, and the ENIO study wasn't yet published. So these guidelines were prior of this. So the first thing that should come to your attention is that really at that stage, and we are talking just about 3 years ago, we didn't have any evidence about the majority of the criteria for ventilator weaning and for extubation in brain injured patients. And therefore, as always we do when we do criteria and recommendations and clinical recommendations, we try to use the common sense. And at the end, what we have understood from the review of the different papers is that the decision to extubate the patients with acute brain injury is a multifactorial component which relies on neurological conditions, level of consciousness, yes, but it does not rely on a specific values of GCS, because it really depends how much the neurological status affects the protective capacity of airway reflexes and factors which are also considered in non-neurological patients. For this, we obtain strong recommendations. We obtain, of course, a strong recommendation even regarding the fact that neurological status itself and alone should be considered as a criteria. But as you can see, we were unable to provide any recommendation regarding the specific GCS threshold to be considered for the decision. So the very famous 8 of GCS that has been told to all of us when we were trainees, in this case is not recommended anymore. It's something that should be considered in the context of the whole neurological and respiratory assessment of these patients. So tracheostomy. Tracheostomy comes after the extubation failure, of course. And again, I would like to start to compare this from the general ICU, with the data that we have on neuro with the general ICU population. And what I was saying to Aaron is that I work in a mixed general and ICU population, and my boss is Professor Pelosi, who is a very famous general ICU intensivist. I do the neuro. And I always tell him that they are very lucky because they have more evidence and they have more criteria in terms of mechanical ventilation and guidelines. We don't have any evidence. In the general ICU population, first of all, they have a clear threshold for what is considered late and early tracheostomy. And basically, they have common recommendations regarding the indication in terms of need for tracheostomy. This comes from a huge number of studies, higher number than those that have been published in the neuro ICU population. And one of the biggest one is the very famous Trackman randomized control trial, which was published on JAMA in 2013. And from these and the different editorials and review papers, expert opinions, in the general ICU population, we know that tracheostomy should be considered to protect airways with risk of aspiration, in presence of dysphagia, prolonged demand of suctioning, different extubation failure. And especially what is important is that a common recommendation is to estimate after day 7 the risk of prolonged ventilation, which is considered as threshold at 14 days, and then eventually to proceed for tracheostomy in that case. For brain injured patients, we don't have these recommendations. We don't really have a real threshold that should be considered. And when we start to think about the trajectories of these patients, should not be, according to what we have said so far, just about the respiratory trajectory. It's also the neurological trajectory that is of fundamental importance. But as you might know, because you are clinicians, it's not that easy to understand which will be the neurological trajectories of these patients, especially in the early phases if we want to do an early tracheostomy for several reasons. Which is the incidence of tracheostomy in brain injured patients. It's very high. And basically over the years, it has changed quite importantly. This is a study that we did with a Spanish group, and what we did was putting together 3 big databases. At the end of the story, we had more than 4,000 mechanically ventilated acute brain injured patients, database from 2004, 2010, and 2016. And we did a comparison between mechanical ventilation settings and the need for tracheostomies, etc. If you read this paper, you will see that there is a huge change in terms of the PEEP use, the PEEP values used. In 2004, the 30% of the patients were ventilated with a zip. And in 2016, just a minority, because we have learned from the general ICU population. Same thing for the tidal volume. In this same study, in 2004, we showed that in 2004, more than 20% of patients were ventilated with more than 12 milliliter per predicted of body weight of tidal volume, so very high tidal volume. In 2016, nearly 3% of these were ventilated with such high tidal volumes. So we have done a big change in terms of the use of ventilatory settings. If you see the data regarding the need for tracheostomy, these are not that different from 2004 and 2016, 17, 19, 16% of incidence of need of tracheostomy. And if you see the time from intubation, this is slightly changed. We are starting to be a bit more, we do a tracheostomy a bit earlier, with a median time of 9 days from ICU admission, or at least from the start of mechanical ventilation. Let's see what the ENIO study has found in this case. The ENIO study found that the need for tracheostomy at the end of the story was around the 20%, so even higher than before. And the median time was 9 days. If you see here, it is like in 2016. So there is basically a progressive reduction in terms of the timing of tracheostomy. And which are the predictors of need of tracheostomy in the TBI population? This is the question that we try to answer using the database of a center TBI study. Some years ago, we used this large database of more than 2,500 TBI patients. And what we found in a Cox regression model for the need of tracheostomy is that, again, age, so similar to the need of extubation, of course, but the presence also of extracranial injuries, and in particular of thoracic trauma, was independently associated, the presence of persistent hypoxemia, and importantly, neurological status. In terms of GCS, in this case, we had to dichotomize, but again, the message is that it's not about the single number, and the pupillary function, which is a mirror of the severity of a neurological injury. And what did we decide regarding the tracheostomy need and the criteria in the consensus from 2020? We had 2 recommendations regarding this topic, 1 strong recommendation and 1 weak recommendation. Again, the first message is that we don't have any strong evidence on this. I will show you soon that especially in the stroke population, now we have some randomized control trial. In 2020, we didn't have any randomized control trial regarding the outcome. So no evidence regarding the indication for tracheostomy in this population, and contradictory low quality evidence regarding again, regarding the indication for tracheostomy. So we recommend that tracheostomy should be considered in patients who have failed 1 or several trials of extubations. And we recommend that tracheostomy should be considered in patients who have persistently reduced level of consciousness. So as you can see, we had to remain very general in these recommendations because of the lack of evidence. In the first point, we then discuss this in this paper together, of course, with the risk of extubation. But the second point, the second message is that think about the trajectories of the patients. If you have a patient with reduced level of consciousness, if you have a patient who has no protection of the airway, there is obviously no point to make a trial of extubation. Why is it so important, and why do we struggle and we fight a lot at the congresses among us regarding the timing of tracheostomy? It is important because tracheostomy is something that now we do every day in our units, and with the percutaneous tracheostomy, it's something that I mean, we don't have to call a specialist to do it. We can do it easily in our units. But we also have to think that every time we do a tracheostomy, we put our patients at risk. Professor Vargas is a professor from Naples, and she's one of the representative of airway management of the Italian Society of Intensive Care. And some years ago, she did this survey, this Italian survey, regarding the presence, the incidence of complications during the tracheostomy. The most frequent complication, early complications, is bleeding controlled by local pressure, which is something that doesn't worry us too much in terms of local bleeding, which can be controlled just by pressure. There are anyway other complications which are okay, less frequent, but not that unusual, like difficult cannula placement, pneumothorax, desaturation, 6% of the patients, pneumothorax in 6.9 of the patients. I don't know if it is if it is because it was an Italian survey. I have to say, but these data are quite scary. False passage, 3%, is not a small amount of this. Bleeding requiring exploration, requiring surgery, 3% of the patients. So we have to think every time we consider to do a tracheostomy that there are early complications, there are also middle-term complications. Again, the most common is bleeding controlled by local pressure. That doesn't scare me too much, but there are also other middle-term complications like cannula extraction, malpositioning, stroma infection, inflammation, bleeding requiring surgery, etc. So from 5 to 14% of the patients, which is not a small number in my opinion. But we also have to think about the long-term functional abnormalities that are related to the presence of and performance of tracheostomy. If you look at the patients who receive the tracheostomy at 6 months, these are patients that in the 50% of the cases have speech difficulties. If you see them at the follow-up, you will see that many of them are continuous cough, have anyway shortness of breath, they have difficulties in swallowing, they have sore throats, they have scar problems, they have chronic pain. These are something that we don't think too much about when we are in the ICU and we have to make the decision to do a tracheostomy. But it's something that should be taken in account when we think about the management of these patients, because it is true that if I do an early tracheostomy, it's also easier to wean the patients. Probably I will need more, I will need less sedatives. I will show you now the effect of early versus late in terms of these outcomes. Probably I have a lower incidence of pneumonia. But if I do, if I think about a late tracheostomy, I can think to do a later tracheostomy because I want to give a chance to my patient to avoid unnecessary tracheostomy and the risks which are correlated to the tracheostomy. What do clinicians think in terms of attitudes of tracheostomy benefits and risk? This is a very nice, very informative, I think, brief communication that was published in 2021 from the set point survey investigator, which are those who then performed the randomized control trial on stroke patients. And basically they asked to the clinicians, which are the benefits of doing a tracheostomy, especially an early tracheostomy to your patients? Most of them replied, I will need for sure less sedation and analgesia. I will need for sure a shorter duration of mechanical ventilation. Probably I can start the physiotherapy much earlier, which is probably true. But which are the potential harms? Bleeding, tracheal injury, infection, unnecessary surgery. and unnecessary prolongation of life support. And here comes also the ethical part of this talk, of which I will discuss at the end of the presentation, and I think it's one of the major issues of performing a tracheostomy. What do we decide regarding the timing of tracheostomy in this paper, in these conference reports? No recommendation. We are unable to recommend, to provide a recommendation regarding the optimal timing of tracheostomy. As you will see, and again, this was before the set point trial, as you will see in the studies that I will show you, the effect on mortality and survival is not completely clear. There is contradictory, low quality evidence. We will also talk a bit about the choice of the outcomes. The evidence in terms of high level of evidence are really too small. And in the panel during the Delphi approach, the Delphi process, which leads to the obtainance of recommendations, there was really a fight between the components of the panel, because it really depends on clinical practice. It really depends on center to center. And in fact, as showed in the sample of the expert that we chose for the clinical recommendation, this is exactly what happens in normal life in general clinicians and in Europe and also outside Europe. This is still Professor Vargas' work, who basically asked to the Italian, but then she performed a second study in Europe and outside Europe population physicians, and she asked which is the most frequent timing for performing a tracheostomy. And if you look, there is a huge variability, especially if you see, for example, the European or outside the European thinking. So in Europe, in the 22% of the responders to this survey, the most frequent timing was before 1 week of mechanical ventilation. In the outside Europe, so especially North America, most of the responders were from there. It was nearly the half of these patients. Quite similar was the response in terms of 7 to 15 days, and then again, huge variability regarding the other time frames. And what about patients who or clinicians who manage only neurocritical care patients? So this is again the brief communication that I showed you before. Before I showed you some results regarding the indication of tracheostomy. These are the results of this survey regarding the timing of tracheostomy. And as you can see here, between nearly the 74% of the responders, 75% of the responders tends to do a tracheostomy between day 6 and day 14. And only the 5% tends to do a tracheostomy before day 4. So it seems that in neuro patients, the clinicians think a bit more when it's about only the specific group of population of neuro patients. They tend to do a tracheostomy after the first week, much more frequently compared to the other populations. And the other things that they asked, which is quite interesting, is that can you tell with reasonable certainty before day 1 if the patient will require a tracheostomy? And always was ticked only in the 3% of the patients. So again, I think that the main message from the studies that we have and that we had so far is that the problem in doing a early tracheostomy is basically that it is very difficult within few days, within 5 days, to decide which will be the trajectory of the patients. It is difficult already for the general ICU population, but when it is about also the neurological component and the assessment of what we have said before, so the protection of the airways, the capacity of the swallow, the gag reflex, the presence of cough is probably even more difficult. And this is in the specific population of TBI patients, exactly what I showed you before, but in an observational study. So this is the sub-analysis of a center TBI. More than 70 centers in the center TBI from mainly Europe, and this is the variability. Again, we found huge variability. In green are the countries basically who perform generally more late tracheostomy, and in red the early tracheostomy. And this is a panel, this is a graph which basically demonstrates after adjusting confounding factors, so considering the severity of the patients, which is the clinical practice in the different centers in the center TBI study. And as you can see in the center TBI study, the majority of the centers do the tracheostomy after the 7th day, despite there are some centers who tends to do the majority of the tracheostomy within the first 6-7 days. We said about variation in terms of centers. We said that it's probably because of the lack of protocol. It's probably because of the lack of standardized guidelines and protocols. It also depends on the type of patients. Of course, this demonstrates exactly what I was telling you so far, that in trauma patients, in brain injured patients, is much more difficult to understand the trajectories of these patients, especially in the gray zone. Of course, if you have a terrible brain injury, it's quite easy, but in all the gray zone, it's really difficult to understand when the patient will wake up, how will wake up, which type of alteration we will have. And in fact, this is a study that basically demonstrates this, because sometimes common and basic thinking have to be demonstrated. And basically, in this study, what Meta and colleagues did was to compare the risk, the adjusted risk of tracheostomy rate in the neurotrauma population versus respiratory failure population. And as you can see, the risk of receiving a tracheostomy is nearly doubled in these patients. But which are the factors that influence the timing of tracheostomy? This is what we try to understand in the second part of our manuscript on from the center TBI. And we were a bit surprised about the fact that if you put together the patients and you divide them in those who received the early or a late tracheostomy, the only differences that you see are regarding the age, basically. You see, for all the other factors, even pre-injury factors, even the presence of hypoxemia, the injury severity score, the neurological status, this was not significantly in this analysis. What was significant was the presence of ventilator-associated pneumonia, so the occurrence of ventilator-associated pneumonia. Those who developed VAP had the earlier tracheostomy. Those who developed during the first days respiratory failure, again, the use of steroids probably related again to the severity of pulmonary infection or the presence of ERDS, and the use of neuromuscular block. So in this study, what we found is that there are not huge neurological reasons, because these patients were assessed in the first 3-5 months to decide to perform or not a tracheostomy. And in most cases, these patients were still sedated. So basically, the clinicians, what we have understood from this paper is that the clinician in the first 5 days think about the trajectories, which is more about the CT scan, the initial GCS. But when you are in the first days, the clinicians probably more consider the presence of respiratory complications, which can delay the neurological assessment of these patients, or, for example, the use of neuromuscular block. But here comes the main issue. Is there an effect on the outcome? And the other question is, which outcome regarding the timing of tracheostomy? So we have understood that it really depends on the clinical assessment of the patients. It really depends on clinical practice. It really depends on center and local protocols. But do we have any evidence regarding the fact that doing a tracheostomy first or later, day 7, is better or worse? Well, there are some evidence on this. Let's start again from the general ICU population. I'll go very quick regarding this. Considering a threshold of 7 days, this is a meta-analysis, the use of the early tracheostomy, reduced VAP, reduced the duration of mechanical ventilation, and caused the prolonged ventilator-free days, but had no effect on mortality. Cardiovascular intensive care unit, again, early tracheostomy was associated with ICU, with shorter ICU length of stay and hospital length of stay, and was associated also with reduced postoperative complications, but still not randomized control trial. So this is not causation, it is probably association. Obese patients, better outcome again in terms of for patients who received early tracheostomy, outcome in terms of proportion of weaned patients from the ventilator. And I don't know which is the situation in the UK. We are now having not, I wouldn't call it a wave of COVID, but we still are admitting quite in a nice, good number of patients with COVID. And this is a study that we did during the first peak of the COVID pandemic. We did a study of on the use of tracheostomy. The timing of tracheostomy, the median timing of tracheostomy in our unit in patients with COVID was around 14 days. And those who, this is a multi-center study, who received earlier tracheostomy compared to the 15 days, which was the median time for tracheostomy of all the unit, had a shorter ICU length of stay, but again, no effect on mortality was found. And this is basically the results of the TRACMAN trial that I mentioned before. Day 4 versus day 10 demonstrated safety, of course, between early and late tracheostomy, but no other relevant outcomes except for the need of sedation. In the brain injured patients, if you only look at the statistical parts and the figures of the meta-analysis, you will see that we have much less data on this. This is again a meta-analysis from Victoria McCready from Toronto, published in 2017. Heterogeneous population, I have to say, of patients receiving tracheostomy with acute brain injury with a threshold of 10 days. So again, some studies use the 10, some studies used the 7 days. And what they found was reduced long-term mortality. So there was a signal on long-term mortality, but if you see, there is a huge limitation in this meta-analysis in terms of number of patients and number of studies, and reduced duration of mechanical ventilation. We, in our study on the center TBI, found that early tracheostomy was associated with a reduced length of stay, better neurological outcome at 6 months in terms of GOSE, but it was not associated with mortality. But again, this was an observational trial, so the statistical analysis is an association. So better neurological outcome is because of early tracheostomy, or maybe those where we consider that they will have a better neurological outcome are those where we think it's worth it to do a tracheostomy maybe earlier and wean them and try to wake them up. We don't know this from these studies. And this is another meta-analysis with very early, so 3-5 days versus late, which is 5 days tracheostomy, another small group of brain injured patients. And the effect was a reduced VAP, reduced ICU and length of stay, and duration of mechanical ventilation with no effect on mortality. Again, no effect on mortality on this larger meta-analysis, which includes heterogeneous population, so not only brain injured patients. But basically what was found in this study is that because of the lower time of hospitalization, early tracheostomy is associated with a lower cost. And same as before, in terms of costs and resource utilization, this is another point that we also have to consider, because we are clinicians, but we also have to think about the financial situation and the healthcare system. And here again, lower cost related mainly to a reduced ICU length of stay and duration of mechanical ventilation in this population. I take the last minutes to discuss about, so we discussed general ICU population, brain injured patients. There is a peculiar population between among the brain injured population, which are the patients with stroke. which are peculiar, especially regarding the need of tracheostomy, because these are patients who have a higher risk of dysphagia and risk of aspiration. If you remember the results from the study, you will probably remember that TBI was a protective factor in terms of need for tracheostomy and risk of extubation failure. Stroke had the highest risk of need for tracheostomy, and that's exactly for the reason I just mentioned. So there are a lot of specific paper on the need of tracheostomy and studies in the specific population of stroke, and there is also a specific score, which is the SAT score that probably you will use in your units to estimate the risk of tracheostomy. And if you look here, the factors that are associated with the risk or estimate risk of tracheostomy, there is of course the neurological function, but there are also the presence of neuroradiological features. So the presence of lesions on the brainstem, an ischemic infarct of more than 2 of the 2 to 3rd MCA territory, an intracranial volume higher than 25 millimeters, and the presence of extracranial organ failure. And if you see, there are a lot of studies which have evaluated the use and timing of tracheostomy in this specific population, so only in patients with stroke. And the main findings are basically that are quite reasonably similar to those that we showed before. So the main findings are basically that early tracheostomy is generally associated in these patients with reduced ICU length of stay, reduced ventilation duration. There are some studies on safety and feasibility. And in terms of predictors of tracheostomy need, again, GCS, respiratory failure, but also specifically neuroradiological and neurological findings are much more important in this population. So the concept is that in these patients, even the CT findings, if you see, for example, a huge ischemic area in the MCA territory, probably in these patients, there is not much need to think too much. These are patients where probably an early tracheostomy can be probably more beneficial. Small studies, some of these that I showed you in the subpopulation of stroke of subarachnoidal hemorrhage, which confirm this. Tracheostomy timing, early tracheostomy associated with shorter mechanical ventilation and shorter time to the cannulation. And in the population of stroke patients, well, you know that the Cochrane says that you can do a meta-analysis even with 2 studies. And so in this study, they did it. I personally don't believe too much in meta-analysis with a small number of patients and of studies, but anyway, in this interesting meta-analysis, the effect was confirmed compared to the previous larger studies. So reduced VAP, reduced length of stay without an effect on mechanical ventilation and mortality. Randomized control trial, as I was mentioning you, the set point group did the survey because they wanted to understand whether it was feasible to do a study with mortality as an outcome. And they did it also because this is a phase 2 trial, the set point trial, randomized control trial of 60 ventilated patients. And the primary outcome and the sample size was set on safety and feasibility. And the trial came positive. So basically, this trial is telling us that early tracheostomy is safe and feasible compared to late tracheostomy. And as you can see from this figure, there was also as secondary outcome the probability of survival. And there was an important signal here in terms of early versus standard tracheostomy, which made obviously the authors and the scientists happy, because we always try to find a randomized control trial who have an effect on mortality, of course, which is the main outcome probably. And so what the authors did on the basis of this first trial was to do a phase 3 trial. And this is the larger trial with 382 patients who were basically randomized to a median time of 4 days versus 11 days, with a threshold of 7 days for early versus late tracheostomy. But as it often happens in science, this trial was negative. There was no effects in terms of mortality regarding early versus standard tracheostomy for the GOSE and for the mortality. And if you look at the adjusted effect of different factors on favoring standard or early tracheostomy, everything was negative. If you see this graph, the confidence interval crosses the one line, so it means that the trial was completely negative. And now let's come to the discussion. And before coming to the discussion and some conclusion, I would like also you to have a think about this. This is a study that made me think a lot, because if you see here, mortality and quality of life after the tracheostomy is quite poor. This is the QL scale, which basically considers the quality of life. And this line here is the line of the threshold of 12, which is a disability. And if you look at one here, the mortality is high, and we know that the mortality in brain injured patients is very high, but also the quality of life is quite poor. And the problem is that the quality of life of patients with neuro who received the tracheostomy is much worse than those who had acute respiratory failure. So we have to think really twice when we think about performing a tracheostomy in these patients, not only because of the patients, but also because of the caregivers. And I found that, in fact, in the majority, this is another evaluation, but in this case, to the caregivers of critically ill tracheostomized patients, these patients, most of the caregivers of this group of patients reported high level of depressive symptoms. So we have to be careful, and we have to think about the person that we treat and what is the environment in which he lives. So the conclusions is that the extubation criteria are defined but not completely elucidated, are a combination of respiratory and neurological factors. The studies that we have available to understand and to decide the risk and probability of extubation are very heterogeneous. Probably the most heterogeneous that we have is the ENIO study, where we had good sensitivities regarding the prognostic model on risk of extubation failure. Regarding the tracheostomy, again, we have a lot of observational studies. We have randomized studies only in the stroke population where we failed to obtain an effect on mortality. We have to consider the respiratory and neurological trajectory. We have to consider the patient in his whole assessment. It's fine to use scores. We all look for scores because it is important, but always individualize the treatment of the patient, the right patients with the right technique in the right timing. And as I was telling you, the evidence seems to support the early tracheostomy in brain injured patients in terms of resources, but not on mortality and functional outcome. But here comes my last slide, and then we can discuss. Are we using the right outcomes for these patients? Do we really think that the timing of a single procedure from 4 to 10 days can really change the 6 months mortality of the patients? Consider this when you read the papers, consider also the ethical issues, and consider the environment of the patients with their families. Because we don't have many evidence, we have started a new study, which is not just specifically on extubation and tracheostomy, but it's more about the mechanical ventilation settings, which is the VentiBrain study. And now the VentiBrain study has concluded its enrollment, and we have 2,300 patients. So this will be probably the largest study on this topic. And I hope that after this study will come with stronger evidence. In the meantime, I would like to thank you again for your attention. I thank you, Aaron, again for the invitation, and we can start the discussion. Thank you.